going to go through the evolution of neurostimulation from unipolar stimulation to bipolar to dual lead, triple lead, tripolar leads, various waveform, tonic stimulation, voltage control, and the newer technology of frequency, burst, and density. And finally, we'll talk about new targets for neurostimulation. I'll spend some time to critically review the most randomized controlled trials that published lately, and finally, a few words on the state of neuromodulation now. Dr. Kumar published this study a few years ago. It was the first prospective randomized trial looking at 100 patients in 5 centers in the US and Canada and others, randomizing patients to receive neurostimulation versus medical management. And as you see here, people who received the neuromodulation achieved 48% pain relief versus 9% of the medical management. Granted that those who received the neuromodulation did very well as far as quality of life and activity and functional capacity, but really the 48% is nothing that we should be proud of. As you know, we had problem covering the back, and people started to use 2 leads and 3 leads. And the first one to use 3 leads was John Oakley, who used tripolar transverse stimulation to cover the back. John Oakley was one of the pioneers in this field, and unfortunately he died in an aircraft crash in the early 2000s. He showed that when you use 3 leads that the VS score decreased by 36% versus 16% with conventional stimulation. And again, tripolar stimulation showed some evidence of ability to steer the stimulation to one side and another. But again, this is not great results that really we can be proud of. Greg, okay. Rick North tried to correlate between the percentage of overlap of paresthesia and pain and the pain relief. So this 3-line represents 3 time frames of the patient, the best results when the stimulator is put, and the results after 6 weeks, and at the end, at the time of publishing this data. As you can see that as the coverage improved, the pain relief improved. And this is really the simple takeaway message from this study. But this study, in a way, showed us that there is no relationship between paresthesia and pain relief. People who have 0% coverage of the pain area still have 30–40% pain relief. And as time goes on, this relationship actually decreases from 70% to almost 50%. And what interests me that these are the people here who had 30–40% coverage of the painful area of paresthesia and don't get pain relief, or did get substantial pain relief. In the early 2000s, the concept of constant current and constant voltage came. And as you know, the amplitude is a result of the voltage over the resistance. With the constant current concept, any sensitive changes in the resistance is adjusted automatically to maintain that the same dose of stimulation reaches the target. While in the constant voltage, you have a head power that stimulates, but based on the resistance, the amount of stimulation reaching the target is vulnerable to the degree of resistance in between. So in theory, constant current is better. So people try to study the differences between constant current and constant voltage.